welcome everybody. This is Christine Buckley from the Brain Aneurysm Foundation. I have the record going because we're going to be sharing this later, or still admitting some people now, but I'm glad there's a good number of you that signed up for this webinar. It's going to be some great information. We are fortunate to have a repeat guest, which is Dr. Jared Cooper from White Plains Hospital. And he's going to be speaking to us today about the cognitive and neuropsychological consequences of SAH. And I know it's a topic that is near and dear to so many of you. Many of you submitted some good questions, and we hope to get to those at the end of the program.
Hey, hi everybody, and thank you, Christine. So my name is Jared Cooper. I'm a neurosurgeon at White Plains Hospital, which is in Westchester, New York. Obviously, I'd like to thank the Brain Aneurysm Foundation for having me back. I love working with this organization. It's really special for me, and I know how helpful it is to everybody listening. So just a little bit about me. I practice cerebrovascular neurosurgery and general neurosurgery, as well as endovascular neurosurgery. So I have a particular interest in brain aneurysms and other blood vessel disease of the brain and spine. And today, I'm really going to be talking with you guys primarily about a topic that I think is often overlooked in aneurysm treatment, which are the cognitive and neuropsychological effects of subarachnoid hemorrhage. And so I have a slideshow. So just, for the sake of completeness, I have no disclosures to report here. And just as a brief overview, we'll be briefly reviewing aneurysmal subarachnoid hemorrhage. We'll discuss the transition from hospital to rehabilitation, and then we'll get into the different types of long-term cognitive and neuropsychological effects of subarachnoid hemorrhage, followed by a discussion of what can be done to aid in the management of these different and unique challenges. And so, like I had mentioned, first we'll describe what brain aneurysms are, just for the sake of completeness here. These are dilatations in the wall of a blood vessel. They look like a little balloon, and they commonly occur at branch points between two blood vessels because that's where blood flow is most turbulent. And they can be congenital, flow-related, due to trauma, or due to infection. Aneurysms tend to occur, like I had mentioned, at branch points of larger blood vessels, but can also occur at the origin of small perforators, which might not be seen on conventional non-invasive imaging. And approximately 90% of aneurysms arise from the anterior circulation. So what I mean by that is, if you look at this image to the left side of the screen, the four major blood vessels in the neck, the carotid arteries and the vertebral arteries, all come up to the base of the skull where they join one another to form what's called the circle of Willis, and branches of that supply the entire brain with blood. The carotid circulation anteriorly or in the front is referred to as the anterior circulation, and it's comprised of the anterior cerebral arteries, the distal internal carotid arteries, and the middle cerebral arteries. And the most common location for aneurysms traditionally is thought to be the anterior communicating artery complex. And then the posterior circulation, which is the vertebrobasilar circulation, is responsible for the remaining 10%. So what is subarachnoid hemorrhage? So essentially, subarachnoid hemorrhage is extravasation of blood into the subarachnoid space, which can cause, what's commonly referred to as aneurysmal subarachnoid hemorrhage, and accounts for about 80% of these cases. There are other causes of non-traumatic subarachnoid hemorrhage, like arterial dissection, dural AV fistula, spinal cord vascular malformations, septic aneurysms, pituitary apoplexy, and then substance use and things like RCVS. Just a bit of background. The incidence of subarachnoid hemorrhage, aneurysmal subarachnoid hemorrhage, is about 10 in 100,000 worldwide, and affects up to 30,000 people annually in the United States. And the incidence increases with age and occurs most commonly between the ages of 40 and 60 years of age, with a mean of about 50. And mortality rates are high, and they can be as high as about 45%, with importantly, significant morbidity among survivors. And just as a bit of epidemiology, the mean age of an aneurysm rupture patient is about 55. It's about 1.6 times more common in women, 2.1 times more common in African Americans. 15 to 30% of these patients have multiplicity of aneurysms. And the risk factors for aneurysm or subarachnoid hemorrhage include hypertension, smoking, female gender, tobacco use, and heavy alcohol use. There's also a familial tendency as well. Um, and so, I like to, whenever I talk to a patient who comes in with subarachnoid hemorrhage or their family, I like to talk to them about what their expectations are when they get to the hospital. I often refer to the first 24 hours as a whirlwind because so many things are going on and we have to act so quickly. So I think it's really important to describe the different phases of the hospital stay. And so I summarize them here, which are, initially the immediate life-saving care, like maintaining airway and circulatory problems. The aneurysm treatment, which can involve clipping or coiling traditionally. The critical ICU period, which can last anywhere from 1 to 3 weeks. Preparing for discharge. This is where a patient is starting to mobilize more and, you're kind of tidying up the endpoints of the hospitalization with the intent of discharging a patient either to home or rehabilitation. And then there's the discharge and rehabilitation phase. So where does rehab happen? So patients can either be sent home, where they can either, participate in outpatient or at-home physical therapy, acute rehabilitation, subacute rehabilitation, or a long-term acute care facility. And there was a study that was done that analyzed trends and outcomes for aneurysmal subarachnoid hemorrhage over the last 15 years and found that roughly 46% of patients were discharged home, 12.8% were discharged to an inpatient facility, 12.6% were discharged to a long-term care hospital, 5.2% to a skilled nursing facility, 6% discharged to hospice, and about 6.8% expired in the hospital. And importantly, the study also found that over the last 10 years, these low and medium Hun-Hess grade groups have had a greater proportion of patients with better functional outcomes being discharged home. And that's probably indicative of like the advancements in treatment strategies within the last 10 years. And, that's not just the technical ability in the angio suite, but also the comprehensive critical care management of these patients while they're in the ICU. There's fewer inpatient mortalities associated with our modern treatments, and therefore the patients are being discharged, more readily to, advanced levels of care, whether it's acute rehab or home. So what can we do for patients in a hospital outside of, our conventional, technical advancements in the angio suite? One of the things that was looked at to improve patient discharge is early mobilization. Prolonged bed rest can lead to dramatic muscle wasting, as we see here, and 5 to 10% have it of patients that were studied in this review show decreased quadricep muscle strength or muscle mass with around a 25% decrease in strength after 2 weeks, and this is more common in elderly adults. And some of the traditional barriers to early mobilization of these patients are the concerns regarding rebleeding, hydrocephalus, and vasospasm. That being said, early mobilization was found to be associated with home discharge and more favorable functional status at discharge. This was further proven in a study from Norway, which compared patients who underwent standard treatment versus early mobilization. And in this group, they had 77 patients in a control group and 94 patients in an early mobilization group. And they found that the early mobilization group achieved higher mobilization levels at discharge. No patients had any falls or inadvertent tube or line removal. And interestingly, there was significantly less clinical vasospasm in the early mobilization group, a greater than 30% risk reduction for severe vasospasm, for each step in this mobilization ladder was achieved if it was within the first 4 days after aneurysm repair. And so they have like this stepwise algorithm here where each patient has to essentially achieve progress in one to advance to the next. So it starts with bed rest, with head elevation, further head elevation in step 2, even more in step 1 and 2, and then sitting on the edge of the bed in step 3, sitting in a chair in step 4, standing at bedside and walking a few steps, and then walking the rest of the room and in the hallway. And these patients did quite well and had better mobilization on discharge and at rehab if they started earlier in the hospital. So I found that was a good segue into, what life is like after you're discharged from either the hospital or your rehabilitation facility. And importantly, we use these scales such as the Glasgow Outcome Scale and the Modified Rankin Scale, which I have pictured here, to track outcomes. And the thought is that a patient has achieved a good outcome if they're oriented, if they follow commands, if they demonstrate good strength in their extremities. But in fact, good MRS or Glasgow Outcome Scale does not necessarily equate to a true good outcome. These scales, unfortunately, severely underestimate psychological distress and cognitive dysfunction, which can lead to extensive problems with reintegration back into society. And, this is a great pictorial example of this in this pie chart, right? This represents a sample of patients with good MRS, right? Denoted as 0 to 3. We can see in this inner circle here, we have patients with an MRS of 0, 1, 2, and 3. And then these patients underwent neurocognitive testing. And in the outer ring, we can appreciate the amount of patients that actually were found to have cognitive deficits despite their good outcome as rated by the Modified Rankin Scale, right? Almost 60% of patients with an MRS of 0, which is the best functional status as determined by MRS, had some sort of cognitive deficit. And so when considering a patient's recovery, we really must consider that, survivors face this potential for physical, emotional, and cognitive changes that can be as small as, something that they are able to get over quickly, but they can be significant and long lasting as well. And I think this diagram really is helpful in illustrating just how common these things are. And just to kind of elaborate on the potential challenges that we see in our patients, they can extend from, physical and mental fatigue to chronic headaches, concentration problems, vision deficits, short and long-term memory difficulties, speech deficits, behavioral changes, loss of balance and coordination, in addition to the things like focal extremity weakness that we more conventionally measure. And when asking patients about the types of challenges that affect them the most after discharge, almost all of them had stated that they continue to have needs, and over 75% of them feel that those needs have still been unmet. Patients report changes in their life with respect to their ability to enjoy leisure activities, work, social and personal relationships, travel, and their finances. And the most common unmet needs are things like fatigue, which is represented in about 66% of patients, memory issues in 60% of patients, concentration in 59%, headache, and anxiety. And one of the more interesting things that I found on this, that I highlighted in the slide, are that in nearly 60% of patients, we can see here in this top row here, they found that they needed more information about the very condition that they were, having treated, subarachnoid hemorrhage. So, a big portion of this is related to needs regarding more information in their own care. And ultimately, all of this contributes to what we would call a healthcare-related quality of life, which is an individual or group's perception of their physical and mental health over time and how it impacts their daily life and ability to function. And it's really made up of a core set of principles like physical functioning, psychological functioning, social functioning, and well-being. And this has been looked at from a global perspective to see what features of aneurysmal subarachnoid hemorrhage affect healthcare-related quality of life. And this study found a number of different factors contributory to a worse healthcare-related quality of life after SAH, which include things like higher Hunt-Hess grade on initial presentation, fatigue, mood, cognitive issues, physical disabilities, female gender, advanced age, single or divorced marital status, lower education, and passive coping style. And so ultimately, I found a good way to look at this a little further is to divide these these qualities of healthcare-related quality of life into three domains, including cognition, mood, and physical function, and really breaking down the components of each of the three of these things to see where shortcomings are and how we can do better as practitioners and how patients can succeed on their own as well. And so starting with cognition, over 70% of aneurysmal subarachnoid hemorrhage survivors are found to have deficits in attention, executive function, memory, language, and mood. And up to 48.7% of these patients with a good functional outcome still experience significant cognitive impairment. Survivors of aneurysmal subarachnoid hemorrhage have accelerated cognitive decline, up to 2.6 times greater risk of developing dementia within 10 years of rupture compared to the general population. And the major determinants of these cognitive deficits include older age, delayed cerebral ischemia due to vasospasm, and the treatment method that was used to manage their aneurysm, which I'll get to in a little bit. So, another study was conducted to evaluate cognitive deficits a year after spontaneous subarachnoid hemorrhage. And this looked at 177 patients admitted to a neurointensive care unit over a 10-year time span. And they employed this neuropsychological battery of tests. Most patients had a good 1-year modified Rankin scale, but as I had mentioned previously, that doesn't necessarily always equate to strength in cognition. 71% of patients had deficits in at least one cognitive domain, with memory deficits being the most prevalent at 51%, followed by deficits in executive function, visual construction, and attention. And of those patients, about 37% had disrupted healthcare related quality of life. And you can see in this diagram, which I think does a great representation of highlighting the overlap between all of these different deficits in cognition that these patients suffer from. With respect to mood, anxiety is the most commonly reported form of psychological distress, and it frequently relates to fears over hemorrhage recurrence or fears about, your ability to return to everyday life. So common questions are, will this happen again? Or who will look after my family if I can't? And this is certainly something that I've seen in my own clinic, and it's worth paying attention to, right? There was a series conducted of 70 consecutive patients with aneurysmal subarachnoid hemorrhage who underwent a neuropsychological assessment with respect to anxiety and depression in particular. And they found that approximately 40% of patients had moderate to severe levels of anxiety symptoms 16 months after subarachnoid hemorrhage. And up to 20% experienced some level of depressive symptoms as well. And this was just furthered in another study of about 45 patients where 27% exhibited symptoms similar to that of PTSD, and about 2/3 of their 45 patient cohort reported substantial fear of recurrent hemorrhage, just illustrating how important it is to be transparent with our patients about the risks and their prognosis based on how they're doing. Interestingly, both anxiety and depression tend to progress over time and can persist for up to 3 years or more. There was a meta-analysis that revealed that the prevalence of anxiety symptoms appeared to increase in the short term with consecutive time points at 3 months, 6 months, 1 year, and 2 years post-subarachnoid hemorrhage. Similarly, depression symptoms can occur and persist for 3 years or longer as well. And this, of course, can have negative consequences on a patient's ability to self-care, their capacity to reintegrate and participate in social events, return to work, and improve their overall quality of life. The predictors for these things tended to be aligned with Hunt score at time of admission, as well as modified Rankin score at about a year, and that was also found to correlate with the use of antidepressants in this patient population as well. And so lastly, we'll move on to physical function. And this is a particularly important component of this kind of model. Um, Fatigue is one of the most commonly reported symptoms that exist in up to 70% of aneurysm survivors when assessed using this FSS questionnaire, which I have on the bottom right side of the slide. It is often considered by ruptured aneurysm survivors as one of the most disabling symptoms that is a long-term symptom. And, in the literature, it's commonly referred to as the invisible symptom because sometimes it's subtle, but it can have very debilitating effects on your quality of life and your ability to reintegrate. Physical fatigue and mental fatigue are the two components that comprise overall fatigue. And kind of intuitively, physical fatigue relates to, muscle performance, whereas mental fatigue is brought on by periods of like taxing cognitive processes. And these things can persist well beyond a year after aneurysmal subarachnoid hemorrhage in, over a third of patients. And one of the most significant concerns related to fatigue is the ability of a patient to return to work. The strongest independent predictor of ability to return to work after aneurysmal subarachnoid hemorrhage is the presence of clinically significant fatigue, which increased the risk of not returning to work by fivefold. Other factors that affected return to work in this particular study included age, WFNS grade, which is similar to a Hunt grade, and active smoking. Just to kind of further this point, of those patients that returned to work, about 34% of them reported a loss of income after subarachnoid hemorrhage, and 24% had experienced an increase in expenses. So, while this seems to be somewhat of a subtle symptom, at face value, it has really detrimental effects on, on a patient's ability to, regain their sense of normal. And, this concept of reintegration after subarachnoid hemorrhage was looked at even further by this group in Sweden who examined long-term quality of life metrics over 20 or more years in patients with what's, conventionally considered a good neurological outcome. And they found that while almost all of the people that they studied were able to return to work, they demonstrated that inability to return to work contributed to a lower quality of life. About half of these patients indicated mild or moderate reintegration difficulties, so it's certainly prevalent. They also were able to show that in addition to fatigue, a lack of sleep, which is a common sequelae of subarachnoid hemorrhage, was also associated with worse quality of life and worse psychological well-being. So, why do these things happen? Obviously, the initial headache, the initial, neuromuscular issues that follow a ruptured aneurysm, this, vasospasm and strokes that can accompany subarachnoid hemorrhage are kind of self-evident in their presence on imaging and can clearly be linked to certain symptoms that one would develop after subarachnoid hemorrhage. But why do these, neurocognitive or psychological things happen? And in large part, this is still unknown, but it's believed to be related to an interplay of multiple things like direct effect from the hemorrhage, inflammation, and damage to the hypothalamic pituitary axis. This figure here on the left kind of nicely describes how an aneurysm rupture can, ultimately result in inflammation and subsequent neurocognitive decline, just in the amount of manipulation to the local and regional tissue that happens after as a response of aneurysm rupture. The increase in blood flow, the edema, the disruption of the blood-brain barrier, and the healing process, which may or may not be influenced by things like vasospasm or open surgical treatment, all have some sort of inflammatory component that can persist even after discharge. Similarly, the hypothalamus and pituitary axis, which I'll get into in just a moment, is responsible for a majority of the hormonal regulation in one's body, and that can be directly affected by aneurysm rupture as well. We'll start with inflammation. And the inflammatory response by nature is one that promotes healing, right? However, that is typically a transient response, but a prolonged immune response can induce pathology. Essentially, like a hyperinflammatory response can induce pathology. And so, it has been shown in animal studies that the onset of these neuroinflammatory processes occur, rapidly after subarachnoid hemorrhage within the first few hours, but they can persist for weeks and even months. And there's since been a growing interest in the use of certain anti-inflammatory agents for the treatment and management of aneurysmal subarachnoid hemorrhage, even in the post-discharge period, with targets being things like TNF-alpha, IL-1 beta, and IL-6, which are inflammatory mediators. With respect to the hypothalamic pituitary axis, the belief here is that the effect is kind of mediated based on the proximity of the circle of Willis and the hemorrhage to the pituitary gland. I mean, you could see an example here in this illustration. The pituitary gland in this particular case sits near these aneurysms that are coming off of the internal carotid arteries, which is a very common location for aneurysm formation. And not only can the pituitary gland be affected just in direct proximity to the aneurysms or hemorrhage, but any stressful stimulus, certainly aneurysmal subarachnoid hemorrhage being a stressful stimulus, can elicit a strong response from the hypothalamic pituitary axis. And it can result in suppression of some of the normal hormonal functions, which can lead to neurocognitive symptoms. So I mentioned earlier that to some degree, there's an interplay or a contribution rather of what type of treatment you receive and what that does to affect your long-term neurocognitive outcome. And so this was studied on several occasions, the first and probably largest of which is a subgroup of the ISAT trial cohort, which is the International Subarachnoid Aneurysm Trial, which looked at patients with unruptured and which looked at patients with ruptured aneurysms to find differences between those that were treated with coiling and clipping. And so a subgroup of this population was looked at for their neuropsychological effects of treatment. And interestingly, in this study, they found that at 1 year, aneurysms treated by endovascular means perform better in a number of neuropsychological domains. And you can see those different domains in this table here on the bottom right. And the endovascular group tended to have less deficits in things like verbal memory, less deficits in general verbal skills, processing speed, spatial working memory, and executive skills. And that being said, this was studied by another group out of the University of Michigan who actually mapped the timeline of these changes, and interestingly found that in patients that underwent aneurysm clipping, they had initial declines in performance across these different metrics like memory, attention, and executive function. But ultimately, over time, and I think they used a year as their time point, they were able to, regain a baseline level of function. So, the point is initially they had a more sharp decline, but then ultimately kind of caught up to the other groups. And in part, this might be due to just local manipulation of tissue or, vasospasm or other things that are contributory to a patient needing to get clipped or the sequelae of having been clipped. All right, so what can be done to manage these neuropsychological effects secondary to aneurysmal subarachnoid hemorrhage? In order to plan cognitive rehabilitation for these patients, a detailed neuropsychological or neuropsychiatric assessment is really important. And not just performing a assessment at baseline, but repeating these assessments at regular intervals is helpful in evaluating progress, right? And there's a whole bunch of different studies that are different assessment modalities that are used. I have a couple listed here. The functional independence measure is on the bottom right, and the disability rating scale is on the bottom left. And these can be used either at rehab, whether that's inpatient or outpatient, to kind of track somebody's neuropsychological progress. There are some other rehabilitation strategies that I have outlined here that can help with improvement in executive function, language, and memory. And particularly in things like executive function and memory, that can sometimes require some interplay between rehabilitation strategies like the ones that I listed before, as well as pharmacotherapy. Another really important modality for management of these neuropsychological effects are different coping strategies. And so the one I have pictured here is called the brief cope model, which evaluates how a person uses 14 different coping strategies, grouped into 3 overarching coping styles. So the coping styles here would be emotion-focused, problem-focused, and dysfunctional strategies. And then there are a number of different coping strategies within those 3 styles, right? And the problem-focused coping style, which incorporates the strategies of things like active coping, planning, and instrumental support, is typically associated with a better healthcare-related quality of life, whereas the dysfunctional strategies, as the name would infer, are typically associated with a poor healthcare-related quality of life. So interestingly, and kind of not surprisingly, patients with greater fatigue and emotional symptoms applied more maladaptive strategies, signifying that these patients were more likely to use these dysfunctional coping styles. Both the patients with fatigue and depression were more likely to use these dysfunctional coping styles, whereas acceptance was actually the prevailing coping strategy in the good outcome subgroup of aneurysmal subarachnoid hemorrhage survivors. And those tended to use more problem-focused strategies, which are, better adaptive strategies. And so, it's important to recognize when it comes to things like acceptance that it shouldn't be considered as giving up, but rather as an active process of reevaluation of possibilities and life priorities. And there's a good quote by Michael J. Fox here that acceptance doesn't mean resignation. It means understanding that something is what it is, and there's got to be a way to get through it. It acknowledges the new reality, in this kind of post subarachnoid hemorrhage life. And that can be very productive. And there are a number of different acceptance-based therapies, including CBT, acceptance and commitment therapy, and mindfulness-based stress reduction that are very helpful in supporting and fostering this this notion of acceptance. And I think importantly, the first step in promoting acceptance is adequate information, right? It's really important to set expectations and be transparent about a patient's healthcare status, and it's counterproductive to advise patients that they will get better simply just by waiting. And so what can we do as practitioners? Talk to our patients. I think this is an understated and extremely important thing that we can do to help support our patients, right? A recent study found that in more than half of the cases, either the patient or their family reported significant or persistent personality changes after aneurysmal subarachnoid hemorrhage, right? We've been talking about that for most of this talk. But importantly, none of the patients had been questioned before by a health professional about these symptoms and their implications. So, a lot of patients kind of secretly suffer from these sequelae of subarachnoid hemorrhage. And another thing that we can do is set expectations by providing information regarding follow-up needs, prognosis, risk of recurrence, and importantly, involving patients in their care, right? Perception of high quality of the interaction between a medical staff and a patient is shown to correlate with low anxiety and low depression scores on self-assessments. So there's clearly a benefit here to involving patients in their own care. I've been a patient, and it's been extremely helpful for me to be involved in my own care. It gives me a sense of contribution and control over my own life. And scores were also significantly lower in patients that felt involved in their medical decisions. What can patients do to try to help get through these types of things? Breaking up tasks into short activities, keeping a daily schedule of activities, trying to link information to old information to help strengthen synapses and memory, simplify explanations, sentences, and conversations, stimulating games, take notes and repeating things to build memory, have a family member or caregiver for assistance, make sure you have a home base or a quiet space to rest and to, regroup, keep a journal. I often recommend that patients keep a journal of their, not just their thoughts and feelings, but, their headache pattern or any sort of symptoms that they might be experiencing. Utilize productive coping strategies and share feelings or concerns with a trusted loved one or caregiver. And lastly, I'd like to just make a note of something on support groups that I think is extremely important, right? Subarachnoid hemorrhage survivors might not always be forthcoming about their distress, and I kind of just alluded to that on the prior slide, right? There was a study that was done that showed that patients who perceive their neurosurgeon or neurointerventionalist as someone who has saved their life may not be eager to complain about things like that they consider to be minor, and that could encompass a lot of this psychological or cognitive problems that we've been discussing. And interestingly, in this cross-sectional survey of patients in support groups, the patients that sought out care from a support group were twice as likely to have clinical anxiety, 1 times as likely to have depression, and 1.7 times as likely to have PTSD-like symptoms than the wider subarachnoid hemorrhage population. And only about half of those participants had reported being examined for psychological distress after subarachnoid hemorrhage by a health professional. And so what this suggests is that patients with neuropsychological symptoms are seeking support from these groups, but may not feel comfortable in a traditional healthcare setting. And so it's really important for support groups like Brain Aneurysm Foundation or the B Foundation, or even your local support group, to address these psychological needs of patients who have suffered through subarachnoid hemorrhage, make their environment comfortable for patients to feel safe in disclosing their symptoms, and to help identify patients with psychological concerns in order to connect them with practitioners who could be helpful for them. And so in conclusion here, I think the overarching conclusion is that outcome really should be considered inclusive, not just of our conventional standards for how somebody is doing on a sensory motor level or a orientation level, but should include quality of life, health status, physical functioning, subjective health perception, need satisfaction, cognition, psychiatric disturbance, and general well-being. Good communication between patients and providers regarding these aspects of well-being is critical to identifying challenges in recovery. Providers should reinforce high-quality coping strategies, therapy, and healthy behaviors to facilitate improvement in well-being. Patients should utilize their resources and have them, readily accessible. So it's up to us as providers to make sure that our patients know where to find these types of things. And don't be afraid to ask for help. Super important, right? If you're a patient and you're feeling some sort of way, it's helpful to know that you're not alone. And part of that is to ask. And that can be helpful in letting us as practitioners know that there's an unmet need. And that's all I've got. And thank you. I'm happy to answer any questions that you guys have. Thanks
Yeah,
for
great, Jared. I do have, Dr. Cooper, have some questions that some people sent in, so I'm going to go through those. But that's a great presentation. I mean, it's such a hard topic, and I do think that there are more practitioners and groups now who are looking at the outcomes and how to make the better for the patients and their families. I just, I'm not sure how quickly if it's going to move, or, is every center and facility going to be the same? But I am hearing it talked about a lot more. I mean, you touched upon this, I think, a little bit, but, someone asked, do you feel more testing should be done after a rupture to determine what someone's cognitive, psychological, and physical problems are? And do you think that's going to become like a standard of practice for people post-rupture?
that's a great question. I think it should be. I think that this is clearly, I mean, the data shows, right? It's clearly an unmet need for patients. And it's a major contributor to their sense of self and their ability to recover and recuperate that sense of self. And, whether a baseline is done in the hospital or in, early stages of rehabilitation, I think it's very important to track these things over time and to have this kind of open communication with not just the patient, but, their healthcare proxy or family in order to, make sure that things aren't being missed.
And another common question is people ask, does fatigue ever go away?
I think fatigue can go away, but I think it's it's a reality that in some patients fatigue can last for years. And that's not uncommon. I've seen that in my own practice, and I've, read about that obviously in the literature. So I think that there are strategies to try to overcome elements of fatigue, but one shouldn't feel like they're singled out if they're experiencing fatigue for years, because I think that that's somewhat common.
Okay, thank you. Another question is, what's the best way to find a therapist near you for whatever that therapy may be that actually understands, the trauma of a brain aneurysm?
Yeah, so that's an interesting thought, right? To answer the first part of that question, I think that utilizing your physician resources or your support group resources is a really helpful way to find local practitioners to help you from like a psychotherapy type standpoint. But finding somebody in particular that is familiar with caring for a patient after an aneurysm rupture might be a little bit more challenging. But I think that therapy can take many forms, and it doesn't necessarily need to be hyper focused on patients who have dealt with a subarachnoid hemorrhage. That can be part of the sharing process that helps both the practitioner and the patient benefit.
Okay. And someone had put into the chat earlier, and this came up last week in a discussion. Is there a higher incidence, or is there a documented incidence of suicide after someone has had a subarachnoid hemorrhage?
Yeah, so I think that follows the higher incidence of depression in patients after subarachnoid hemorrhage relative to a standard population, but I don't know the specific numbers on that, like how much more likely it is.
Okay.
But I think sorry, go ahead.
No, go ahead.
No,
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 go ahead.
I've seen that unfortunately in patients who have long-term disability, right? There's an element of depression that arises out of not the financial burden or their perceived burden of themselves with their family and loved ones and lifestyle, right? And that can be very debilitating. So it's really important to pay attention to those factors of a patient's well-being.
And you mentioned in your presentation, and someone actually asked a question about the likelihood of developing dementia post SAH. So, and you said, I think there's a 2.6 times more likelihood in those 10 years. Is that a newer statistic, or has that been known for quite some time?
I want to say that that's been around for at least, 5-ish years. I don't
Okay.
recall exactly where that study was published or what year rather, but I could certainly find out. But I know
Yeah.
that that's something that's been looked at. And that dementia doesn't necessarily mean like, full cognitive loss, but, an element
Right.
of memory loss or cognitive disability that is exacerbated relative to the general population.
Someone also asked, does anyone ever fully recover from SAH? I know
Wow.
it's a tricky question.
Yeah, that's more of a philosophical question, right?
Yeah,
Uh, I've seen plenty of patients, fully reintegrate back into what they would consider a normal life. But I think that it is a major life event. And I think that it, to a degree becomes not what you identify with, but a part of your identity or a part of your experience in the world. And I think that um, losing that or getting rid of that is a difficult feat, right? I've been a patient myself, not with aneurysmal subarachnoid hemorrhage, but I think, as humans, when something happens that is a major life event, it's hard to completely rid yourself of the thoughts of what has happened in your life.
yeah. Then there were a couple questions, and I think it just falls into the whole recovery of, cognitive and neuropsych, but, is it possible that someone can become more angry or suffer some kind of personality changes in their recovery?
Yes, absolutely. I mean, we see personality changes with varying degrees, from things that, can range from anger, to depression, to irritability, to disinhibition, depending on, some of the different aspects that I brought up, right? The neuroendocrine component could relate to that, but also just the location of the hemorrhage can have effects based on like structural defects from the hemorrhage.
Someone just asked if fish oil can improve mild cognitive deficits after SAH.
I haven't looked into that. I'm not opposed to fish oil, but I'd have to look into the data before, like, completely
Recommending it.
endorsing that. But I don't think
Yeah.
that I think that there'd be little harm to that.
Okay. And how often should someone return for an appointment to make sure the aneurysm doesn't recur? I mean, it seems like there's been a few people here and someone from South Africa that said they have had any follow-up. So what is it for like clip coil post-rupture when someone should be followed?
Right. That's like a fantastic question because it's the thing that's probably asked the most, amongst patients, and clearly there's some sort of um, global concern for that, not just based on the questions being asked from all over the world here, but also in the literature. Um, and moreover, patients can feel some sort of sense of abandonment if they haven't seen their practitioner for a while. So the way that I look at it is aneurysms treated by different modalities require different degrees of follow-up. Um, Clipping traditionally requires less follow-up, because if the aneurysm is completely eliminated, then the recurrence rate is extremely small, whereas it's higher in patients who undergo things like primary coiling. And it's somewhere in the middle in the other ways the aneurysms can be treated with flow diverting stents and intrasaccular devices and things like that. So for for clipping, I tend to follow patients for at least a year and then do non-invasive imaging for a particular period of time. With aneurysms that are treated by coiling, I tend to follow them a little bit more frequently up front and then space it out, presuming there's no recurrence. But while there's no real firm answer for how long somebody needs to be followed, I think one of the most important things is making sure the patient has adequate primary care or general neurological follow-up, as somebody who can be like a home base for them. Because while they may not necessarily require a surgeon to keep saying that the aneurysm is no longer there, they should have somebody that they can keep seeking out for continued follow-up for not just the aneurysm, but any other sort of sequelae that they might have or other life problems that they might have. And, that's familiar with the circumstance. I find myself talking with primary care providers quite frequently just to say, hey, this person has an aneurysm. We treated it with this. It looks like it's gone. We either need to follow it in a year or 2 years, or we don't need to follow it, but you should know that this is what went on with the patient. And if there's any issues regarding the aneurysm or concerns, then, I'm happy to see them again or talk to them. I
Right.
think that requires a good degree of communication on the physician side. But I think it's really important in kind of establishing a network for the patient.
Another question, is it normal to not have memory of the rupture just the night before, per se?
Yes. Yeah, it's extremely common. I have, innumerable patients that tell me they don't remember anything, which is, regarding the rupture event,
Yeah.
which is really interesting, right? Because, the patient and their family have completely different perceptions of what happened, right? And so their experiences are vastly different, even though they have to do with the same thing.
And who should be on a care team on the on the rehab side post rupture? Like you said, you don't necessarily need to go back and see your surgeon, but is it good to, find a neuropsychologist, or if you have physical limits, to find that therapist?
Sure. Yeah. So I think neuropsychologists are a fantastic addition to a care team if you have one locally. That there aren't a ton of them, but they're excellent and they're really helpful in aneurysm survivors. Um, I think that a support group can include a lot of things, right? Starting from your family or people that you trust or love is important. Having a primary care provider is extremely important. I know that this is like a day and age where most people just seek out to have specialists, but once you've had a major life event, having a primary care provider is really important to be like your home base to manage all of your conditions, the aneurysm being one of them. If you're having like prolonged neurological effects like persistent headaches, or a limb deficit or something like that, then having a neurologist can be useful for that as well. In medically managing things like headaches or spasticity, or neurologic pain. And then having these support groups is another part of the care team that really shouldn't be overlooked, because while therapy like psychotherapy or CBT is really helpful in allowing somebody to kind of speak about what their concerns are, I think that having other people who have had similar walks of life to talk to is like an irreplaceable form of support.
Agree. A double clip question here. What's the percentage of a clipping rebleeding, and how long can a titanium alloy clip last?
They last forever, and the likelihood of rebleeding, if the aneurysm is completely secured, is less than 1%. It's very low.
Another question is, someone after their hemorrhage about 2 or 3 years later seemed to have some problems with her eyesight and hearing, and she hears the sound of her voice echo when she speaks and has a hard time hearing others. Could this be from the hemorrhage? And it all started 2 or 3 years after.
Oh, interesting.
Yeah, it
Uh,
might be hard to answer, but see
yeah,
what happens.
that's a tricky one. I'm not sure. I mean, I suppose it depends on, where the aneurysm rupture was or what symptoms you had prior to this, but um, it could potentially warrant additional workup like an MRI and an ENT evaluation.
Um, I think that's most of the questions. I think you touched upon things that people had already asked, but I did want to say, you had mentioned too about, patients feel their life was saved by their doctor, so then they maybe not want to come forth and then complain or say anything. And I think that's something important to address with folks too, when they are being sent home, or whether they're going to a rehab, or to discuss with their families, be grateful that you are here and that your life is saved, but that doesn't mean that you don't have the right to say, okay, why am I more tired, and how do I get help for this and get help for that? So I think that's an important message that we all should share and make people understand and realize. Yeah, your surgeons, whoever treat you, they're amazing. They keep you here, but that, you're sent home in a different way. So I think that was a nice point to make. It is important to speak up.
Yeah, the care does not stop at the treating of the aneurysm. When it's funny, I somewhat jokingly but seriously tell my ruptured aneurysm patients, like, we're friends for life now.
Yeah.
And that's just how it goes, right? I think that breaking down some of those barriers between, like, somebody who might be perceived as like, oh, you saved my life, and so all of these things in between don't matter. That's extremely important, right? We need to be approachable as practitioners so that patients feel comfortable, disclosing these kinds of things that are going on, because they're real problems.
Yeah. No, I want to say thank you very much, Dr. Cooper, again, for your time and all this information. I think it is great. Again, there are support groups out there. Dr. Cooper starting one in June at White Plains Hospital, so that's amazing. And I just think it's important to have these conversations and get questions out there. Again, this has been recorded. We'll get it out to everybody who did sign up, but I just thank you all for being a part of this, and, pay attention to all things BAF, follow us on social media and help us get the word out there. And I hope you all have a great night. Thank you again, Dr. Cooper.
Thank you, everybody. I really appreciate it. Take care.